Thanks very much for the invitation. I really enjoy coming to talk to many of you. I see there are many physiotherapists, but I'm sure there will be an audience of a different type. So welcome to the perioperative program. That's what we call it, POP. POP means energy. And that's what's important for these patients who are coming definitely from various backgrounds. The majority we deal with cancer. But of course, I mean, I will give an outline of what we do at the McGill Rehabilitation Unit. So I don't have any conflict. So today I want to discuss with you the perioperative trajectory. So remember, majority of our patients going for surgery, and that's where the rehabilitation was started. I started about almost 10 years ago. And the importance of physical status, risk assessment, attenuation. So really patient-centered. Then I introduced the physiological consideration of multimodal rehabilitation. And then, of course, I will try to understand the integration of rehabilitation. This is a lady who had as you can see here, octogenarian, who had quite an amazing past medical history with a major weight loss, extremely well educated, with a master in theology at the age of 60, and before she had a bachelor, various bachelors. And when I was asked by a GP to take care of her, because he heard about we were doing something before surgery, I met her, and she was quite despondent. She was very bright. She could read colossal newspaper. Then after 10 minutes, she would forget. But she really had she was not sure whether she really wanted to do or not. So I said, well, I called the gynecologist and I said, you know, I think if you want to operate, she has all these factors. The one worries me very much is the frailty, of course, the weight loss, and of course, the fact that she had a major posterior delirium. So it's a combination of functional status and so on, and malnourished. So I said, well, you know, you have to give me some time to put in shape. Can you give me 3-4 weeks, 4 weeks, let's say? Well, why I point out this example? Because we know the poor functional status is related to poor postoperative outcome. This is surgical endoscopy study. We actually show that whether you are independent or partially dependent, totally dependent, that affects your postoperative outcome. As you can see here, if you are in the red, totally dependent or partially dependent, you have more surgical complications, pulmonary infections, cardiovascular, and so on, mortality. So it is actually quite important to think about functional status is really important to take into account. This is a very elegant study we published in Annals of Surgery, where they look at the TAG, time up and go, that you know very well. Very simple indicator, walk test. And you can see that the one who actually slow TAG are the one who actually survive before. And this is actually quite elegant study done as well, where they look at the trajectory, initial trajectory, as you see on your left, functional trajectory of no disability, mild, moderate, and severe. They go for surgery, primary major surgery, or age of 70, and you can see surgery recovery could be rapid, or gradual, or partial, or little. But if you take even, let's say the person with mild surgical trajectory, you can see that approximately 27% are going to finish in a partial recovery. And this is worries us because it means that we are able to operate, but not necessarily we are able to put patients back to their family, back to society as we wish. So what it means is that functional capacity or fitness, as you measure with either the METs or 6-minute walking test or TAG, all these that you know very well, definitely have an impact on morbidity, length of stay, quality of life, and mortality. So why I think that is very important. Now, the risk calculator of the American College of Surgeons identify 15 variables predicting risk. Some, of course, are not modifiable, but some are actually modifiable. And you see, on the right, functional status, BMI to some extent, albumin less than 35. And of course, malnutrition and mental health are not assessed, unfortunately. So we went through the ERAS program. We have done so well. We have been enhanced recovery after surgery. Many of you know we're able to enter the grid of stress, preoperative condition. There is not really much into that respect. What about functional status? So how do we optimize our patients today? We are excellent in persistent medical conditions. 50 years ago, we would counsel patients if the blood pressure was not right and so on, or the glycemic control was not right and so on. Today, we do everyone. We manipulate extremely well, good with our internists. But do we do anything in functional capacity and psychological status? What about the nutrition? What about the physical? What about the mental? I can't get a physiologist, a psychologist to see their patient in the pre-op group. What about nutrition? Only 10% of our patients coming to pre-op are seen by nutritionists. So this is the trajectory of surgical care. As you can see, we start from the moment the surgery is identified to go through the continuum of care. And we have been great intraoperatively. We are great with enhanced recovery, post-operative, immediately post-operative period. But what about pre-op? What about pre-habilitation? So this is the concept that we developed years ago. It was very much for the geriatric population, where you have a level of functional capacity, as you can see, the straight line. And this is the preoperative period if you don't do anything. And then you wait for surgery, you get surgery, and that's a hit. And your functional capacity goes down dramatically. You go to your surgeon and say, the first 4 weeks, you will see in his clinic, and he will say, doctor, I'm tired, I'm fatigued. And the recovery really depends, will take time. Elderly patient, we know, takes 6 months to come back to what they were before. So the question is that intervening after surgery is too late. Patients are tired. They don't want to hear anything at all. They don't want to hear moving exercise and so on. They are worried about that the stitches are going to break. That's what happens most of the time. And they say, the wife said to the other, don't move because everything should be straight, don't worry about it. So the patient becomes much more sedentary. But what about before that, while we're waiting for surgery? And that's called reserve. It means we're increasing the reserve of these patients in order to see they come down as a result of the stress of the surgery, but definitely will not to the same extent as you can see here in the black line. And the recovery obviously will be faster. So this concept of theoretical model, we will see how we apply. So we developed at McGill this concept of multimodal interdisciplinary rehabilitation. Why is that? Because came up, I started with exercise. I found very much that many of our patients are to some extent malnourished. They are depressed, anxious. Why don't we look at the patient as overall, body and mind? And that's what functional reserve is about. So if we put all our effort in increasing the functional reserve of the highly high-risk patients, the idea is to increase the functional reserve, which is a protective against the stress of surgery. That's why you have the medical optimization, obviously, anemia control, glycemia, blood pressure, alcohol, smoking, absolutely. But don't forget the psychological intervention. Don't forget the nutritional intervention, especially who are malnourished. And of course, increasing the strength and increasing the aerobic component of the flexibility and balance. So, exercise. Why no exercise should be a prescription? But not just come and go, do what you want. Because I think there is a difference between physical exercise and therapeutic exercise. Physical exercise, any movement. Therapeutic, really prescription indicated with frequency, intensity, interval, a type of exercise. To give you an example here, as you can see in this slide, you have a training which takes into account the frequency, the intensity, the duration. It could be various forms. And then, of course, we have a physiological adaptation, cardiovascular, and of course, skeletal muscle. When we do resistance, is the concept of the muscular benefit of the resistance exercise, especially in adults of the patient at risk. 8 major muscle groups, 3 sets, 8 repetitions that you know very well. Well, why aerobic? That's what our devices are, aerobic and resistance exercise that I don't want to spend much time on that. Very simple with TheraBand. They don't need to spend much money. Whether aerobic or resistant, one is better than the other. Well, it seems to be that in fact the combination is the best. Food. Food should be a prescription. Food is medicine. So if we change our mentality of our patients, that the food is actually medicine, empower them also to eat much better. And that's where the Canadian Malnutrition Task Force came up with a quite concern that 45% of patients in the hospital are malnourished. That's frightening. So, of course, extend hospital day. Now, avoid the preoperative malnutrition. Nutrition at least 7 days a week, with or without exercise, reduce the hospital length of stay by 2 days. Nutrition, of course. We have to think about energy requirements, a balanced meal, and of course where they are, but it has to be properly assessed by a nutrition. Doesn't matter any nutrition? No, not really. These are quite interesting slides which actually show the structural nutrition to promote anabolism and decrease the catabolism. Remember, you're dealing with a patient who is catabolic, is going before surgery, already catabolic, and he's going for surgery, it's going to be more catabolic. So protect that by decreasing the catabolism and promote anabolism. So the question you're choosing, possibly the animal, which are the left animal proteins versus the vegetable protein, of the mixture, obviously. But what is interesting is that simple things like eggs, they have a great power of maintaining or promoting anabolism. So you don't need to go complicated and whey protein, obviously, because supplements are important. Now, the elderly, you probably deal very much, many of you dealing, is very clear here that on your left, the fractional synthetic rate on the y-axis, you can see, which is the muscle protein synthesis. You can see here that if I give food to a young person, will respond in an anabolic response, increasing protein synthesis in the muscle, while the elderly cannot, because it has an anabolic resistance. The same in the high-risk patient. But if I give exercise to the older patient, definitely will respond to some extent as a young patient. So the combination of exercise and nutrition seems crucial. And this is the picture here represented. Exercise is an anabolic stimulus, the amino acid potentiates effect. So you really have a synergistic effect. So where is the evidence? Proof of concept. I present here 4 studies that we did in our centers, where we looked at patients either colorectal or esophageal or bladder or prostate. And we can actually, or lung, sorry, prostate. We can actually see, you remember the diagram I presented to you, the reserve. Here we are, the blue is increasing, is pre-hab group, represented here an increase in functional capacity measured by the 6-minute walking test, simple test that you probably know, and really is consistent before surgery and then continue after surgery. In the colorectal, that anti-oncological we published, these were large studies we found over 500 patients. We actually see that patients at 8 weeks, the pre-ab, 80% were back to baseline compared to 40%. Now, what about clinical outcomes? Well, this is systematic review, quite reasonably recent, to actually show that rehabilitation, maybe exercise in this case, has an impact on morbidity. And then, of course, you have this study coming from Spain. We actually show that patient post-operative complications are reduced, endurance time is increased, and of course, patient complications per patient are significantly reduced in the rehabilitation group. Cardiovascular, of course, infection. And this is a study where we improved also us. We found that the comprehensive complication index was decreased if patients walk more than 19 meters, which is significantly relevant for 6-minute walking test during the preoperative period. A recent study just came out in annual surgery where postoperative complications were reduced if you use a rehabilitation from 72 to 42%, 43%. See a study coming from our center where actually we look at improved disease-free survival, rehabilitation, 5 years in colorectal cancer, especially in stage 3. Who can benefit? Should we put our money in all of them? Definitely, what we found that the one who walk less than 400 meters, which is very seems to be the cutoff, below which elderly are not able to function and be mobile independently, definitely are the one who benefit most, as you can see in blue, during the preoperative period, if they do rehabilitation. The one who are rehabilitation very fit doesn't really matter, but the control, they decrease. And decreasing even after 4 weeks after surgery, and they just barely come back at 8 weeks. While the blue, the one who are less than 400 meters, increase. The malnourished one are the one who actually benefit most. You can see here, if you are more poor nourished, malnourished on your slide, on the left side, you can see the 6-minute walking test is actually low. But these are the ones on the right who actually receive rehabilitation are the one who actually benefit most. What about patients who are depressed? Well, here again, if you're high depressed, a high hard score with a high anxiety and depression, you'll walk less. But definitely, if you lift on the table, next table, you can see that basically they actually are the one who benefit most. So, what do we say to our referral surgeons, oncologists, physicians? We say, look, send the patient to have a problem with the function, frail, DASI, 6-minute walking test, or weight loss, or BMI, they may be sarcopenic obesity, or major depression, or they might have some of the medical surgical complications. So you can then screen your patients for function, for nutrition, and you decide if a less of cutoff is present here, then you assess it. It becomes much more, say, involvement in terms of you do something like body composition, you cardiopulmonary testing, and so on, and then you decide the intervention, which one doesn't fit all, obviously. So what's happened to this lady? Well, we changed completely the food. We put her on a high protein. We remove all the sugars. We modulate the energy intake. We remove her from the chair, aerobic and resistance exercise. The one you can see sit on her left is a kinesiologist. And then education, we just play, somebody came and played the games and with the family and so on, Sudoku, for instance. Anyway, she went for surgery. She recovered. She had a minimal blood loss. She lasted 2 days, no delirium, became more active. She became independent. She lived another 2 years. And she's able to actually celebrate 90 years of birthday. Now you can see here the physical component, the mental component, the 6-minute walking test increased dramatically, and the neurological, neuropsychiatric, neuropsychology assessment improve. So what is our take message? Is physical fitness, nutrition, and mental state are absolutely important in our patients. And I think we reduce capacity, a higher risk of postoperative. So think about reserve, prepare for them. If they are not ready, don't send for surgery. Negotiate with our surgeons. They will understand that the impact is enormous and the data are coming more and more. And I think the population that you're dealing with, transplant, makes such sense. We have done 2-3 cardiac transplant. We have been asked to do some lung transplant. And I know that kidney and liver transplant are coming our way too. And we love to cooperate very much and think this is a very challenge full of interest from mechanistic point of view to understand more exactly what happens to this patient. Thank you very much. And I will be happy to answer any questions.
Thank you so much, Dr. Carli.